You're all very welcome to this seminar in the UCD School of Psychology, and today we have Associate Professor Suzanne Guerin speaking to us on knowledge transfer, an evidence-based approach. And thank you very much for taking time out from your busy schedule to talk to us today, Susie.
No problem, Alan. I'm actually really excited. I was just saying, I feel quite nervous, and I don't get as nervous as I used to before a seminar, but I've got so much invested in the work that we've been doing around knowledge transfer that I feel under a bit of pressure. So I might not be my usual calm self, so I'm going to see how I get on. Thanks for coming along. I am really excited to talk to you today about the work that myself and a large group of colleagues have been doing in knowledge transfer. And I suppose today is a formal outing in the School of Psychology for AnyTrack and Kindle, which I'm going to explain over the course of the presentation. So I am going to try and keep the presentation quite tight, and because I'm really keen to hear your thoughts and your questions, because this is very much a work in progress. So I need to mention the two projects and to name the wonderful teams that I've had the chance to work with. So AnyTrack is a project that's developing an evidence-based model for the transfer and exchange of research knowledge. And the exchange is between research, policy and practice. And this is a project funded by the All-Ireland Institute of Hospice and Palliative Care. And I've worked there with Professor George Kernahan, who's from Ulster University, and then three fantastic research staff, Lucia Prohovdova, Mary Jane Brown and Conal Tunney. And this, as I said, this is very much a work in progress. We've just finished the first paper from this study from phase 1, and we're hoping to wrap phase 2 in the spring. So I'll say a little bit more about the structure of the project, but I do want to mention my fantastic colleagues. And then the second project that I'm going to use as an example is our Kindle project, no copyright infringement intended. And this is our knowledge, innovation, dissemination, learning and exchange project. Again, with the Institute, but funded by the HRB KEDS programme, which is a knowledge, education and dissemination programme. And the colleagues there are Tara Murphy, who's in the Institute, Phil Larkin, who's with the School of Nursing here, Charles Normand, who's in Trinity, and then Emma Nicholson, who was of this parish. He's now a project manager, postdoctoral fellow on that project. So I'm going to draw really mainly on these two to talk about what we've been doing. But I want to start by setting the wider context, and I've highlighted here some terms that have become, I suppose, really common within, particularly for those of us who are doing a very applied research. The idea of obviously applied or health services research is nothing new. But implementation science is a fairly recent term that we hear, and it explores the way in which developments from research, particularly around trials and evaluation research, are implemented in the real world. Quality improvement is no stranger to the service setting, but it is part of this wider context. And then translational science or translational research picks up a lot on that idea of how do we make sure that research moves from the academic site or from the research site to practice and is translated. And then we've had this growing use of terms knowledge transfer and knowledge translation. And I'll say a little bit about how those two terms relate to each other. But this is the context that a lot of us working in applied health are working in now. And we're being challenged by funders to have dissemination plans, to have knowledge transfer plans. And there's a lot of people working in this space already, and there's a number of dedicated research units across the world working in this area. And I've just mentioned three. The Centre for Translation Research and Implementation Science in the US is one. In King's College London, they have a Centre for Implementation Science. And even in Ireland, we have the jointly government and philanthropy funded Centre for Effective Services. And to some extent, these organisations are established to promote effective implementation and knowledge transfer, both from a research and a practice point of view. But they do also draw on those arguments of quality improvement and things like that. And CES is a relatively new organisation, but would work to be, I suppose, a broker between research and practice. They're not necessarily situating themselves in either of those two fields. From an academic point of view, there's also a lot of journals in this area. Implementation Science is one of the top journals. I suppose it's all in the name. But you've also got Clinical and Translational Science, and also BMC have BMC Health Services Research, which is really positioning itself around this transfer translation framework. So when I talk about knowledge transfer and exchange, what do I mean, and why have we adopted that phrase? Well, there are lots of concepts in this area, and I've touched on two, the translation and transfer issue. And the way I think about it is transfer is the overarching process, but part of the process of transferring knowledge is that you must translate it. So translation is part of that process. But as with most areas of psychology and research, there's so many definitions that we decided to just pick a position and to hold to it. So we've adopted this definition, which is a combination of Kiefer and Mitten. And it is the idea that KTE, knowledge transfer and exchange, is an interactive process. And that's why the inclusion of the word exchange is key. It's not just researchers on high delivering to services at the front line. It is a much more active interaction there. But the purpose is to increase the likelihood that research evidence will be used in policy and practice, and also to enable researchers to identify more relevant questions that come from the policy and practice field. So this is the definition that we've adopted in our work. Now, a model of knowledge transfer is nothing new. A straw poll when we started this project suggested that there were over 60 in the area of health research alone. So ones that people may be familiar with, Paris by Kitson is one of the most commonly discussed and cited, but also Dan Schroeder's CFIR model and also the Ottawa model of research use. But sometimes it can feel like you're climbing a mountain of acronyms and a mountain of models. And one of the things that we were conscious of was that there are similarities and differences between these models. So, this is Paris, and Paris has three core components. It's got the idea that you have the evidence, this is your knowledge, you want to do something with it. And you're doing it in a context, so you've got the idea here of the idea of culture, leadership, and perspectives on evaluation. And then you've got the facilitation, the actual process by which these things move and interact. So, this would be familiar to a lot of us as key parts of our work. One of the interesting things about something like the Consolidated Framework for Implementation Research is that it teases out a little bit more the context piece. So CFIR identifies an inner setting, so the immediate context in which you're researching and which you're transferring, but also a wider outer setting. And importantly, it talks about the distinction between an intervention, so a change, a service development, as being at a phase of unadapted, but also being adapted through the process of implementation. And then the last one I'll mention is the Ottawa model, because the Ottawa model does work to try and break down, I suppose, both the flow of the process and the key components. So you'll see that it talks about ideas of the potential adopters for this change that you're trying to implement and how their positions, their attitudes and awareness will impact it. It also recognises the environment. But interestingly, when you get to implementation, intervention strategies, often you find with these models that there's not a huge amount of detail, that this is where you transfer. And how do you transfer? Well, you just transfer. And what we were really keen to do was to try and tease out some of those similarities and some of those differences across these models. So in terms of the AnyTrack project, as I said, it was funded by the All Ireland Institute, which is supported by the Atlantic Philanthropies and HRB. And what the Institute was conscious of is establishing itself as a key player in the area between research and practice and policy. It wanted to maximise the potential of research to inform practice. So what it was looking for was more guidelines for implementation specific to palliative care. Palliative care is an interesting field because it's one of the few areas of research and practice that really embraces spirituality as one of its key domains, alongside the medical, the physical, the psychological. So our project aimed to develop and implement a palliative care specific knowledge transfer and exchange model. And this was our process. We started with a systematic scoping review where we were looking to the broad area of health services research and to identify and synthesise the models that were in that literature. Phase 2 is a series of case studies where we engaged with research teams and invited them and asked them and begged them to take on board the model, to apply it and to report back their experience to us. And the ultimate outcome is a palliative care specific model. We adopted a position of wide dissemination from the very beginning, and we were lucky enough to have the protocol for the scoping review published in 2015. which makes writing the methodology section of the actual article hard because you can't plagiarise yourself. But here's a little overview of the systematic review findings. We started off with about 7,500 records, including duplicates. And through the process that's outlined here, we ended up with 79 articles that met our inclusion criteria. And the inclusion criteria focused on, again, that health setting, that application of a model. And one of the key challenges was we needed papers that actually described or presented information on the model itself. So I've just highlighted there, as part of our screening levels, we did have double screening on both the abstracts and the papers, and we had high rates of agreement on that double screening. And where the two screeners disagreed, we had a third reviewer. But ultimately, of the 298 articles, 30% were retained for full analysis, but 5 additionally were found to have fatal flaws. We adopted a fatal flaws approach to the systematic review because we didn't want to exclude papers for low-level reasons, for less important reasons. And the key fatal flaw was if the paper didn't give enough detail on the model. So 5 papers were excluded for that. So we ended up with 79 papers, which was just over a quarter of the full text that we screened. And when I say we, it was very much a we task. There was anyone who's done a systematic review will know that there's an awful lot of work involved in that process. Just to give you a sense of those 79 papers, because I think it gives us a snapshot of what's happening with knowledge transfer and exchange and implementation. The majority of these papers are published in the last 10 years, so this is a relatively recent phenomenon. The 2 most common locations are the United States and Canada has a really strong record around implementation science. The papers were conducted in a wide variety of settings, although all health services. And I've just mentioned there that just over 60% of the papers were identified as being relevant to palliative care, and that was either because of the setting, for example, a hospice, the population, advanced cancer, or indeed the knowledge being transferred, maybe symptom management or end-of-life care, things like that. So the majority of the papers were directly relevant to palliative care, but we were synthesising the models across both. So in terms of the models that were being discussed, across the 79 papers, we found 87 mentions of models. So obviously there was duplication there, but some papers were discussing multiple models. And this is a word cloud that just highlights the frequency with which these models appeared. And unsurprisingly, Paris was the most common model, but so was the lesser known unnamed model. And this was where authors were talking about implementation and knowledge transfer, but not drawing on a named model or something that was quite unclear in its name, but there was still detail on the nature of the model. But I think, as you can see, with all of those other models being mentioned, there is a lot in this field, and it's understandable why there can be some confusion about what we should use. So in order to synthesise a model that was based on these and underpinned by the quality of evidence of a rigorously done systematic review, having identified those 79 papers, we conducted a qualitative analysis of the information on the model. So I've outlined the process here. We were trying to find a balance between the interpretive power of qualitative research, but also the rigour of good quality, credible qualitative research as well. So as you can see, 2 researchers independently reviewed the data. Even when we were extracting the data, we had second extraction or double extraction on a proportion of the data, and Geraldine Boland, who's here today, very kindly did that task for us. As with Braun and Clark's model of thematic analysis, 2 researchers independently did an initial analysis of the data and identified what are called candidate themes, possible themes, and then we met to discuss these and to agree those themes. And then we did a final check where a third researcher took 10% of the papers and coded the data physically for those themes to see if we got good agreement. So we were really happy with the rigour of the process, but as an ultimate, I suppose what some people would call sanity check, we also presented the initial model to a group of researchers with a background in health and palliative care, and we asked them to discuss the model with us, and I'll say a little bit more about that in a bit. But this is the really elaborate first iteration of the model, and anyone who's been in my office will see that this is still on my whiteboard because I'm afraid to erase it. And this was from the evening that myself and Conal Tunney, who was doing the analysis, spent thrashing out what we saw on the data, what we felt was key from that initial thematic analysis. And I think you can get a sense of the sort of dynamic interactions that we felt were being represented. But we couldn't present this as our model, it just wouldn't look well. So the second iteration was the one that we presented to our colleagues at a workshop. And this was trying to highlight this idea that the knowledge, the message that you're trying to transfer, the audiences that you're transferring it to, the context, the immediate context in which you're doing it, will be influenced by the processes you adopt to inform that transfer. And what we were trying to represent was the idea that all of this exists in an outer context, a cultural, social and economic context. This is the third version of the model, and it's important because what we did was we went back and looked at the frequency with which key ideas, key components, key themes were evident in the data from the systematic review. Because what we were struck by was that there were several areas that actually were really prevalent across these 79 papers. So it's not surprising that in 60 of those papers there was a focus on the message to be translated or transferred. That message should be needs-driven. That message should be credible. And I'll comment a little more on those sub-themes in a moment. But again, commonly these models talk about the stakeholders and talk about multiple stakeholders in the process, not just the researchers, not just the practitioners. And again, not surprising, the process of transfer was frequently mentioned. But what struck us was when you got down into the nitty-gritty of what the process was, actually there were very few systematic methods that were being discussed. So if you can see there on the slide, the frequency of individual processes is quite low compared to the actual overall reference to process. So what we were struck by was that if you were using these models, you weren't getting an awful lot of information on the how to do it. The local context is really frequently mentioned, 44 of the papers. But what we think is one of the real novel elements that's come out is the lack of focus on the wider social, cultural and economic context. And for any of us who were doing health services research during the recession or during multiple recessions, we know that trying to communicate the benefits of research and the benefits of research-informed practice can be really challenging when a service has no money, has no resources, can't afford to implement them, or when there's difficulties, staff difficulties or stresses, when staff don't necessarily feel in a position to be innovative, to be involved in change. So this isn't really highlighted in a lot of the models. And the other thing that we found that was infrequent was any discussion of evaluating your efforts at knowledge transfer. There was lots of discussion of the process, the practices, the messages, but there was very little reflection on how do we know if we've been effective? How do we know if our knowledge has landed? And I'll say something about that key phrase later on. So this is AnyTrack. This is our evidence-based model. It's based on a rigorously conducted systematic review, a rigorous qualitative analysis of the models as we found them in that systematic review, and it highlights these 6 key components: the message, the stakeholders and the processes all interacting with each other within the immediate local context, within the organisations in which the researchers and the practitioners are working. It's not just the practitioners. So in an organisation like UCD, there are areas of research that are promoted, that are encouraged, that are seen as being strategic, and there are areas of research that are seen as being more niche or more individual. That sort of a context will influence that process. Stressing the wider social, economic and cultural context, we think, is a relatively novel component of this model, and highlighting the need to evaluate your efforts, again, is something that we're really keen to push. I think it can be very easy as a researcher to present the information and to know you've done that job and to feel that the project is done, whether it be a workshop or whether it be a seminar or whether it be a peer-reviewed publication. But this model would suggest that there is a real need to be more evaluative around that. I want to take just a few minutes to say a little bit more about the core components and their sub-components, the themes and their sub-themes. The social, cultural and economic context and the evaluation, there was no real strong sub-themes there. I suppose they are what they are. It was very, very straightforward. But there were a number of these sub-themes that were either very clear and very standard, as I showed in the previous slide, or else actually were not being highlighted. For example, the idea that multiple types of knowledge are valid was very rare across those papers. Only a small number of papers talked about qualitative, quantitative, mixed methods, different informant groups. But we think it's a really important factor now, particularly with the growth of process evaluation, as recommended by the Medical Research Council in the UK. There is much more qualitative data being done in health, qualitative research being done in health services research. It's no surprising that the knowledge must be credible. It's no surprise that the knowledge must be perceived to meet a user need. But what's interesting is who's the user. I had a researcher say to me, if I'm doing a piece of work on methodology in palliative care, that's not serving a user need. And I said, well, it is if you realise that the researcher is a user and other researchers can use that knowledge. Sometimes there's a tendency to think of the user as always being the service provider, always being the client, but other researchers are users of our knowledge too. In stakeholders, again, involving multiple stakeholders was very common. It's not unusual to know that you're going to be dealing with different people. But we came up with this term knowledge beneficiaries because we want to distinguish between knowledge users who would be practitioners and policymakers and service providers. But then the clients and families that they work with are the people who hopefully will benefit from that knowledge. So knowledge beneficiaries are not frequently discussed, and again they are a key stakeholder. And the last one that I'll highlight is this idea of marketing knowledge. Now, the process section is really interesting because it highlights factors like skill in this area. It highlights the idea of targeted and timely activities. I think knowledge transfer has really pushed researchers to move away from the idea that your dissemination is done at the end of the project. Increasing use of blogs, social media, and working papers, things like that means that we are being expected to be engaging in dissemination from the very beginning of a project. And I'll use the example later of how participation can be a key message from the very beginning of a project. If you want to promote participation, you need to disseminate that message. But the one that is interesting to me is marketing knowledge, because researchers aren't necessarily skilled at this idea of marketing, about knowing how to take a message and adapt it for the audience, about knowing how to adapt it for multiple audiences, and about knowing how to make sure it lands, and it lands to be heard. And I think it's an area where there is a huge potential and a huge need around training, support, resources for researchers. Not all researchers, but I think definitely it's a skill set that's key. So the sub-components are as important, and as I highlighted here, some of those sub-components were very rarely evident in the literature. So multiple types of knowledge was evident in 9 papers. A diverse range of dissemination activities, 6. So there's some really interesting patterns in here that we're hoping will be useful. So I want to just give you 2 examples of the model in action and wrap up hopefully again by about 20 to quarter to. So the model in action, the first actual way we used the model was we used it on ourselves. So when we decided that we were going to present an initial iteration of the model to our colleagues in the health and palliative care community, we decided that we were going to do it using the model to inform us. So we developed a self-report case study of using the model to transfer the knowledge of the model to our colleagues. So it's a little bit meta, but bear with me. So we were invited to be part of the Institute's Palliative Care Research Network annual symposium. I'm a member of the Palliative Care Research Network. It's an all-island group of researchers from a diverse range of disciplines, all working in the area of palliative, hospice, palliative and end-of-life care. So we were given the opportunity to do a workshop with our colleagues in the research network on the model. So we decided that we were going to have to start as we meant to go on. So we developed some visual materials that we could give to individuals in advance so that they could reflect on the model. And we also developed a very interactive workshop that would allow us to present our findings, both in terms of the process of development of the model and the findings, because we wanted to reassure the audience of the credibility. And we did some interesting things. We brought in a stenographer, a court reporter, to actually record the whole discussion so that we could actually physically record, and sometimes with audio recording in a large group it's hard. We also gathered notes. There were phases of small group discussion, and we had chairs and scribes appointed in each of those small groups to feedback what was happening. And we recorded all this information, and we conducted also some follow-up interviews as well. And here's what we found in terms of our own practice of using the model to inform our work, and also hearing from our colleagues. So in terms of our message was there is a need for guidance around knowledge transfer. We have used rigorous procedures to develop this model, and this model highlights a number of key components that may be useful to researchers. So that was our message. In terms of the stakeholders, we were really lucky. This symposium had funders, researchers, early career experience, and it also had patient and family advocates there as well. So it was such a mixed group. It was really a perfect dissemination opportunity. They don't come along very often. And as I said, in terms of our process, we had presentation and discussion, we provided materials, and we were also conscious that a lot of the researchers in the room had projects that were moving towards dissemination, so they were thinking about it. In terms of some interesting things that came out, the Institute, which was obviously coordinating the event, was seen as being a key funder, but there were also researchers from organisations that weren't being funded. And because of the work of the Institute, there was a real interest in the room in knowledge transfer, or maybe they were being nice to us. But in talking with them about the role of the social, cultural and economic context, it was really insightful to have researchers and practitioners talk about the pressure on services being a challenge, but the emphasis on evidence-based practice being a positive. So there were these two competing influences. And there was also discussion of the knowledge economy, which again, those of us in the universities are very aware of. And in terms of our evaluation, because again, we want to stick to our own model, we're currently doing a series of interviews and surveys with researchers who took part in that workshop a year later to talk to them about whether they've taken anything of the model forward, whether on reflection they see any value or any limitations to it. So we're hoping by the spring to be able to report formally the findings both from this case study and 4 other case studies where researchers are using our model. So we found it very useful, but obviously we're very biased because we've developed it. So the second example I'm going to tell you about is Kindle. Again, our Knowledge, Innovation, Dissemination, Learning and Exchange project, and it took a long time in a room to come up with that acronym. So in the Kindle project, probably because I was at the table, but there was a real openness amongst the Institute and amongst the research team to use this model again. The aim of Kindle is it's not a project on knowledge transfer. It's a project which has knowledge transfer at its heart. The aim is to take a series of funded projects. So the Institute has between 8 and 12 directly funded and indirectly funded research teams who are doing research on palliative care. They all have their own dissemination paths and their own dissemination plans. But what we were conscious of was the potential to maximise the impact of these projects by doing a secondary analysis of what we call their dissemination products. So to gather together all of the activities that they had engaged in disseminating their own individual projects and to analyse them in order to identify key themes in this research agenda. What are the key messages? So the model was central to our practice. So for example, AnyTrack informed the principles of the Kindle project. So we were committed to multiple messages at many stages of the process. The image that's here is an infographic that we developed instead of an invitation letter. So we didn't do a traditional email to our colleagues telling them about our project and asking them to be involved. We worked with a designer to develop a very visual representation of how we wanted to gather the knowledge activities of our partners together into a group of products, a database, and then we wanted to use secondary analysis procedures to distill this knowledge into a series of high-level messages that cut across those projects. We were interested in whether there were messages that were common about recruitment of participants. We were interested in whether there were messages that were common about the nature of palliative care as they experienced it. In terms of the practices in Kindle, again, we were very influenced by the model. We adopted a parallel approach to our dissemination. We disseminated from the beginning. And this is a blog that we set up on day one with the aim of sharing information about the project, about its ongoing findings as they emerged. So we had the blog as being key. And then in terms of our products, so our actual processes, we weren't just limited by or guided by the focus on peer-reviewed publications. We sought funding to create 5 videos, 5 animated infographics that would communicate those messages in a much more engaging, much more dynamic way. I feel it's very strange that I'm talking about being dynamic and engaging and I'm talking and no one else is, but we'll get to that part. So we used AnyTrack as a model to inform our practice. And this slide just gives you an idea of, I suppose, the timeline of the project and how we used some of those processes to help inform us. So when we announced the project, we did it with the infographic, and we used that infographic to call on our colleagues to give us their dissemination products. And the dissemination products, the database itself, it's 179 products, and they range from a single tweet, 140 characters, up to a systematic review. And they include newspaper articles, conference presentations, and interestingly, mostly traditional dissemination. 3/4 of the products are conference presentations and peer-reviewed articles. So there's an interesting pattern there, very little of the non-traditional activity. We use the blog to encourage people to share their dissemination with us and to keep everybody up to date on where we were. We're just in the middle of a thematic synthesis of those products, so an analysis of what are those common messages. But a key thing that we're doing is over the next 3 weeks, the initial analysis, we've identified about 12 core themes and a number of sub-themes around each of them. And they include things like participation and recruitment and the challenge of ethics in this area, always of interest to researchers. But also the fact that a lot of the studies highlight the need for integrated and holistic care in palliative care. But we have these initial findings, but again, because we want this to be an interactive process, we have 3 reflection groups at which we'll present the initial findings and discuss them with key stakeholders. One group are patient advocates, second group are policymakers and service providers, and a third group are researchers. So very similar to the development of AnyTrack, we're feeding the research back in an early phase to help refine it. And this will inform our development of videos, workshops and podcasts, which with our stakeholders within the Institute, we will disseminate as widely as we can. And as I said, this is the Kindle blog. I'm supposed to post a report on it from a recent conference, so that's hopefully going to go up in the next week. But really interesting, really good news that we got this week was that the protocol for the Kindle project was accepted for publication in BMC Research Notes. And a key factor of Kindle is that we requested funding for open access publications and we targeted only journals that allowed for open access. So again, we're trying to be informed by our own practice. So a couple of key points from my perspective, from our perspective, and then I'd be really keen to hear yours. There is no doubt that knowledge transfer and exchange, and we keep that exchange bit in the name, is a non-linear process. It has multiple stakeholders and it's relevant at different and multiple stages of a research process. I think the days of we disseminate peer-reviewed journals at the end is probably, if not gone, going. Not that it's not still part of the process, but it's not where we start our dissemination. The aim of the work that we've done is to support researchers to effectively promote the transfer and exchange of research knowledge to and between relevant contexts. Again, we want to move away from that idea that the researcher presents the information to everyone else and it's a one-way street. We want to see it as research moving to and from policy and practice context, but also to and from other researchers. And because those connections work, those connections happen. We've all had the idea for a project based on a conversation at a conference. A real reality check for us, though, relates to that term I used earlier of knowledge landing. And it's not a term that I've seen anywhere else, but it's a term that I'm really comfortable with, because knowledge transfer and exchange can inform change in practice and policy. But I think it's inappropriate to expect that the outcome of good knowledge transfer is change. You can't assess or evaluate knowledge transfer and exchange on the basis of whether the service changed, whether the new model of practice was introduced, whether the organisation took on board the programme, because that is so multiply determined that it's actually giving yourself too high a target. So we talk about the landing of the knowledge being available in an accessible, meaningful, engaging format for practitioners and policymakers as being the aim. So it's knowledge landing, not knowledge utilisation. That should be the standard, because we can't be responsible for the knowledge being used and used appropriately, because we know that research findings can be adapted to suit the context. But there is no doubt that if you have really good knowledge landing, if you transfer and exchange your knowledge in a way that the message gets across, you are much more likely to have effective use of knowledge. And it's when knowledge is delivered in a passive way or delivered in academic speak rather than practice speak that you can completely understand that there would be a challenge in hoping that research has an impact. So just to say, our next steps, my next steps, the model's next steps, where is AnyTrack going? It's been really fantastic. There's been a huge level of interest in this model. I do feel like a parent with a child who's sort of graduating from college and people want to give him or her a job. We received seed funding earlier this year to actually explore the relevance of the model in health services research, because one of the things I stress is that the systematic review was not done on palliative care studies, it was done on health services research studies. So AnyTrack as it exists at the moment, without the refinements that come from the case studies, is not limited to palliative care. So I'm working with Frank Doyle, who's a graduate of our programme here in RCSI, and George Kernahan, a collaborator on the AnyTrack project, to do a study looking at health services researchers' views of the model. We're hoping to get that started before Christmas. In an effort to be multiply active around dissemination, we're doing workshops at both the PSI conference and the Health and Social Care Professionals annual conference to actually work with researchers and practitioners about how do you do this, how do you reflect on your message, how do you reflect on your processes. There's a lot of interest in using the model, and just in the last month I've been involved in the dissemination plans and the KTE work packages for 2 Horizon 2020 projects, which went in earlier this month, and just last week 2 HRB investigator-led grants. When you're a methodologist, you often get asked to advise on these types of projects, but it's really great to be being asked to be involved in the knowledge transfer piece as well. And all 4 of these projects have really interactive and dynamic knowledge transfer plans, starting from the very beginning and including at the end implementation guides. How would you implement the service? I am desperately today trying to finish an application to the IRC new foundation scheme, because they've got some funding for collaboration between academics and civic society organisations around knowledge transfer, and the paper on AnyTrack is ready to go to implementation science once I fix the references. So there's a lot of interest in the model, and it is keeping us very, very busy. But it's really easy to be busy in this area because it's really sort of energising, I have to say. So I'm just going to finish by thanking all of the researchers who I'm working with on this project across the island of Ireland, and obviously very grateful to the funders who have put their faith in us to do this piece of work. And I'm really keen to hear any questions or comments or critiques of the work that we're doing, because as I said, it is a work in progress. So thank you very much. Thanks, Karen.
Thanks, Susan. That was really interesting, and I'd like to hear more about it as it goes on. I suppose my question would really be how you see. So you were talking, for example, about how dissemination now, the new route starting earlier, and not just being through the traditional peer review route. But I wonder how you view the role that peer review plays as sort of a quality check on work. and that by starting to disseminate results maybe before it's gone through, and as I think we all know that when you submit a paper you're totally confident in it, the reviews come back and you realise there's a huge flaw that you hadn't realised before, and you re-evaluate. So I'm wondering, is there a danger maybe to this of kind of skipping that quality check process?
Yes. I think there's already a lot of change happening in relation to that, and it's not recent. I mean, clinical trials and randomised control trials for a long time have had, I suppose, that safety valve of if the findings are overwhelmingly positive at key points in the project, that they may in fact roll out the intervention to all of the participants. There's an ethical issue about delaying access to an evidence-based treatment, so that's been there for a long time. In other disciplines like economics, they have a long-standing tradition of working papers where you are presenting work in progress, and that findings may change as that process continues. I think there's a need to be aware of the point that you're at. It's not sort of randomly disseminating and being very definitive. So with Kindle, one of the first sets of findings that we disseminated was that information on what proportion of the products were traditional versus non-traditional. So once we had our database of 179 products, we were able to say very easily that 3/4 of them were traditional. And that's a huge finding. And we're going to be interested in looking at whether the quarter that are non-traditional are more likely to be early career researchers who may be more open to it. And I'd be very confident in disseminating information like that. And it goes back to that point of there being multiple messages. So we sometimes assume that our main message are our findings, but that's not always the case. So Kindle has highlighted that recruitment of participants to palliative care research is really hard. You've got lots of gatekeepers, lots of protectiveness. You've also got the challenge that participants can die while they're taking part in the study. So we've argued, and we've applied this in the two Horizon 2020 studies, is that the very first message that we must disseminate is why is it important to take part in this research? It's nothing got to do with the findings, but it's a key message to the success of the study. So I agree with you that if your main message is the outcome of the study, there's only certain points at which you can disseminate that. But for many of us, there's multiple messages. There's lessons learned from methodology, there's lessons learned from ethics, there's lessons learned from engaging with stakeholders. So if we move away from the idea of a singular finding to the idea of multiple messages that relate to many stages, that's the ongoing dissemination. I would agree with you. I'd hate to see the sort of findings of a study based on an underpowered interim analysis. But we're thinking very broadly about messages. I hope that answers your question.
No, absolutely.
Okay.
Susie, I think related to that, I can't remember all the sub things within the message, but there's something about the goals of putting the message out there, in that whether this dissemination was a time when we were open to review or feedback, or whether, and this, I know that's linked to what you said. I'm just wondering, is that integrated into, it would be more in the message side rather than the stakeholders?
Well, I suppose one of the challenges is that as we've highlighted in the model, the message, the process and the stakeholders are so intertwined, because you have to adapt your message for the stakeholders, and certain stakeholders won't be interested in in certain messages. So we've all had the experience of writing a report for funders where the methodology is in an appendix at the end because they're not really interested in it. So those three things are so intertwined that I don't think you can think about them separately. But so yes, you should be thinking about the goal of the message, and I suppose that's part of that combination, because if the message is you really should take part in this research because it's very valuable, well, obviously the goal there is to increase your recruitment. If the message is this is really important research and the findings will have real significant implications, the goal may be to secure further support for the project. It's recognising that though the messages can be very different at different stages, but will be different for different stakeholders, and because of that, the processes that you would use for different groups will naturally vary. So in the workshops that we're designing, we're really looking at getting researchers to think very laterally, and practice and policymakers to think very laterally about what are important messages to them, what works for them in terms of dissemination and communication. I mean, if you just use that term instead of dissemination, it's a much more natural idea that you will communicate differently based on the audience. So I don't know if that answers your question.
It does. Do you mind if I ask another? It's just related, I guess, but it strikes me that this model will, I think, improve the research itself rather than just improve dissemination. Because you're talking about how it will shape and develop, and you're getting feedback along different stages, so peer review will happen as it goes. But it also strikes me that it will slow the process down, and that, not as a bad thing, but that it just reminds us that good science can be slow science, and that it seems like that could be a potential drawback in order to improve the research.
Again, I think that applies if you focus on the final message. Yes, it could slow the final message. One of the projects that we've looked at in the Kindle project is a study in Belfast, which is of a condition called cachexia. Cachexia is really common in certain chronic and life-limiting illnesses, and it has a really significant effect on patients. You're unable to eat, and you can very slowly find that the patient is starving, and it's so challenging. And the study was focusing on psychoeducational intervention for cachexia, and they could not find participants. I think over the course of 2 years they got 8 participants, really small numbers. And they wrote a paper after the first 18 months, which was about their difficulties in recruitment. And it's a hugely important paper in this area. So they never set out to write that paper. They never set out to have that message, but it's become a key output from their study. It's become a key message. So again, I so go back to my response to Kira's question. I think we do, it's very easy for us to focus on, we've been funded to X, so the learning of X is our ultimate goal. But we've all had the experience of, over the course of research, lessons being learned. And we think, well, I must remember to write that paper after I write my findings paper. So yes, it could slow the process of getting to the final dissemination, the end of the study dissemination, the point at which you file the folder on your computer in completed projects. But I think it opens the door to a lot more ongoing activity, which in and of itself will slow things down. But I think those messages that come during that process are as valuable as the ultimate finding, and they may be unexpected. So it's like slow cooking, it's good, but not if you're hungry. Anything else?
Susie, I wonder if you could talk about the issue of fidelity. And I'll tell you treatment fidelity, and I'm asking the question in this context. In clinical psychology in universities, we've developed a very wide range of interventions for children and adults with psychological problems. We know for many psychological problems, anxiety, depression, conduct problems, ADHD, and so on, what works. We do know that.
Yeah.
And certainly when we train people inside the university and they go out and they implement those treatments, they often do a pretty good job. When attempts are made to disseminate those treatment packages or those treatment processes more widely, things begin to fall apart because the practitioners don't implement the treatment manuals with a high level of fidelity. They think they're doing it right, but actually they go out and measure what they're doing something completely different. They're not doing what it says in the tin. So I'm just wondering, in your model, how do you, can you just, I mean, I can make a guess, but I'm wondering if you will talk about how you address that issue of quality control, of dissemination of knowledge. How will you make sure that what scientists find out, gets out, and how that's accommodated within your model?
There's two comments that I'd make. One related to the broader area of implementation science and one related to dissemination. So from a broad implementation science perspective, we know, and it's really influenced by the MRC framework, that there is a growing focus on what's called process evaluation. The idea that alongside a trial, whether it be randomised or quasi-experimental, that you have a piece that explores the process of delivering that programme, of what works, what doesn't, what do people do, what do they not do. And I think process evaluation has given us an opportunity to learn lessons about fidelity, to learn lessons about deviation, and most importantly to learn lessons about acceptability and utility to clinicians, so that if you're designing this wonderful intervention, but you find during your process evaluations that actually being available 4 nights a week for 2 hours to deliver the model is not acceptable at all to practitioners, that process evaluation allows us to learn lessons that can help us target those fidelity issues, or making intervention more fidelitous, as is one of my favourite words at the moment. But I think from a dissemination point of view, there is a product, there is a message, there is a process that researchers, in my experience, don't often get involved in, which is the actual development of an implementation guide. So if your aim as a researcher is to conduct your evaluation, to report it back to your funders, to your key stakeholders, to your peers through peer-reviewed publication, and that's the science, to what extent are researchers then involved in developing a document that tells practitioners how important it is to do it this way and why it should be done this way, and to actually go out and be involved in the workshops that train the practitioners to do this. So it's a combination of implementation science giving us tools to understand why people deviate, and also the ability for one of our products to be a guide that isn't a peer-reviewed paper, isn't about why this intervention is so great, but is focused on what do you need to know to deliver this, and why should you deliver it this way? I don't know if that answers your question.
That's great, Susie. Thank you.
Okay. Conscious of time. Holly?
I just have one question about the readiness is key theme that you have up there. I was just wondering how you determined whether an audience is ready. I know that you talked about you had groups and obviously they were ready for information, but kind of how you define whether a different kind of group, I know you had lots of kind of methods of dissemination.
Yeah, so the readiness is key is something that did really come out in the analysis, and it is that idea that where you want your research to land, where you want the knowledge to land, you have to know what's the lay of the land there. How ready are they for it? So in our workshop, we knew that this was a group of researchers who were moving towards dissemination. So we hypothesised that they would be interested in hearing about how to be effective in your dissemination. So we felt that they were ready for this information. That's not always so cut and dry when your message is about practice or is about lessons for services and you're not sure of the readiness of those organisations. Now luckily there are actually a lot of tools in the implementation area. There are a lot of tools that allow you to assess an organisation's readiness for change. And areas like work and organisational psychology have developed some nice tools. So there are tools and techniques that we can use out there to formally say, well, if organisation A was to implement the findings of this study, they would need to be willing to change their hierarchy, they would need to be willing to change their staffing model, they would need to be willing to take on board research findings. And there are tools available that will allow us to see whether an organisation is in the position to do that. And it all exists prior to this. It's not that we've developed them. It is related to just change management, quality improvement, and those areas that are connected. So we didn't look at any element of organisational readiness, but in our workshop we were talking to the researchers at a point at which they were ready. But interestingly, I've had this conversation recently, I think even as researchers in the universities, there's a bubbling awareness of non-traditional research impact and non-traditional activity. So in UCD, they're starting to use altmetrics to record downloads of papers, not just citations. They're also looking at social media impact of papers. So I think the research community is more ready now than they have been before to hear about non-traditional dissemination, to hear about multiple methods of dissemination, because there is that bubbling interest. So I think there's a readiness for that. I can't imagine that the hierarchy of UCD would be delighted if we all stopped doing peer-reviewed publications. I think there would be a strong conversation to be had with your head of school if you did. But again, it's seeing it as being a more complex process with a lot more opportunities for dissemination than the more traditional ones.
That's a good question. Yep. Can you comment on the use of Twitter, blogs, the non-traditional methods of communicating about your research, the pros and cons?
Well, I think the main pro and con is that it's a skill, and it's a skill that not large numbers of academics and researchers are familiar with. Some are great, some are not. Science communication is a real, I'd like to say talent, but no, I think you can learn it. Is a real skill. I mean, the ability to communicate anything in 140 characters is a key thing. So, for example, you might see a common mistake, which is a tweet will go out saying, read our paper here, but it's not an open access paper. So there's very simple things that can be effective and very simple things that can be ineffective. So I think like all tools, it depends on the wielder of the tool. And if the wielder of the tool is skillful and has that ability to think of, well, on social media, who are my audience? Who do I want to share this information with? I think then you're going to use it more effectively. But you do have to think about where the audience is going to take it from there. So if you are tweeting about a paper that's written in high science, it's only going to be accessible to high science. So I think it's a tool that is as good as the wielder of the tool is. And I think it's an area that lots of researchers are keen to know more about. And then there are some science communicators who are just fantastic. And the London School of Economics has a Twitter feed and a blog that is spectacular. It's so accessible, it's so on the nose, it's so relevant. I mean, I get excited whenever I get a new tweet from them to see what they're saying, but the skill is really out there. But I do think it's an area that researchers may need a little bit of guidance on. You know?
Susie, that's a great point to finish on. On behalf of all of us, thank you very much for a really thought-provoking presentation.
Thanks.